And good evening to everyone. Place your name and campus in the chat so we can have it recorded that you're here. Look at your name on the screen and make sure that your first and last name matches the roster. We have about 30 seconds. Okay. I'm going to call the official start time and make sure that we're recording here. So go ahead and place your name and campus in the chat again. The last class takes their exam on Friday evening, afternoon. And so the exam analysis will take place at 5 p.m. Eastern Standard Time on Friday, this Friday coming up. And grades will be posted shortly after that exam analysis. You know, we don't give thumbs up, thumbs down, smiley faces, any of that information. We just wait until the last class takes their exam. And then we do the exam analysis, meaning that we go in and look at the questions and everything. And then we will post. And then we'll place an announcement in the announcement section with the grade. So again, the exam analysis will take place on this coming Friday at 5 p.m. Eastern Standard Time and no later than 6 o'clock. The grade should be posted, but you will receive that announcement when it is completed. All right, so we're going to still push our 15-minute break toward the end. We really didn't use up one of our 5-minute breaks, but that's fine. We'll just keep going until we at least cover a good bit of our content here. All right, so exam one has been taken. I know, and I've said this during week one, and it's the same time, but it just seems like you all that the time goes by faster after you take this exam one. I don't know if it's because you have clinical, if you have preceptor, if you have all these class projects and everything, and then more things are taking up your time, you know, for the next couple of weeks. But I say that just to, you know, so that you can be proactive, start looking at the things that you can delete, rearrange, put on pause, you know, and only you can answer that. You know, you want to include, you know, your work, your family, and all those things that you're responsible for. So just think it through. Because, you know, after these first 2 weeks now, everything is moving forward. So, and then you all are right here at the end. And so, you know, once you get to the end, you know, is that you're at the end, you know, there's no extra credit, no extra work. So just making note of where we're at and how things are going to just kind of move forward. Okay. So the next exam, the huge chunks are, you know, the huge concepts, which, you know, remember these are next gen exams. So you have to know the content and then be able to apply it. There are some questions again that will ask you, you know, define what a apple is. But most of them you have to be able to know what that apple is, pretty much how, you know, the kinds of apples, how it was grown, the temperatures and all of that in order to really answer the question. So the huge concepts we have is care coordination, communication, leadership, and collaboration. So those are all of those involve communication, all of them involve leadership, but they all kind of like overlap and they are connecting. But we have care coordination, communication, leadership, and then collaboration. And then even though that they are, I don't know, unnamed, I mean, unnumbered, there's not even a number, the number of team members that's on our team, the healthcare team, but you know, who's right there in the middle? The nurse. No matter if it's the PT, the ST, the dietitian, the healthcare provider, all comes to the nurse. So we collaborate. We want to make sure that we're culturally competent, that we are communicatively competent so that we can communicate both effective and appropriate. Because we're right there. They're coming to us. They're coming to us because we're that main hub for that patient. And so competence should be continuously evaluated. Remember, we're a healthcare providers, so we're signing up to be life learners. So things that probably happened 10 years ago are probably not happening now, even if it's that one step. So it's a continuous process. We're continuously learning. We should be continuously evaluating ourselves for improvement to ensure high quality patient care is actually given. You all will be asked to do those surveys, and you've been asked every term to complete those surveys at the end. And so we hope that you provide feedback because this is a continuous process. We want to be able to provide the best high quality assistance while you're getting your foundational education so that you can move forward and be that nurse. So competence should be continuously. And what do we do? We're evaluating ourselves. If you're working at a job, they do like those evaluations every 30 days, 60 days. They have every year. They do have those time frames, but we should be as healthcare providers looking at our own selves and evaluating and trying to improve upon what we can do. Whether that is our skill set. Once you get your license, each state usually requires continuing education units. And you pick what those continuing education units are for the most part, unless you work at a job and they specifically want you to have certain things. So that's your opportunity to do a self-evaluation and say, well, I'm working in this setting. What other skills? Is there a webinar? Is there a conference where I can actually go and improve upon my skill set to ensure I provide that high quality patient care? Communicate initially, we're considered as a novice nurse, NOVICE, because we're new, and so we do take that in consideration when we are placing nurses in, situations. For example, do we give a novice nurse a stable patient that needs a dressing change, or do we give the novice nurse a unstable patient that needs a dressing change? Which one would we give the novice nurse? If we said a novice nurse is a new nurse, brand new nurse, which one of those patients should we assign or should we expect the novice nurse to be taking care of?
Stable.
Exactly. While, the only tasks that were needed for both patients was a dressing change and pill medications. But because that new nurse, has to gain their footing and experience in that setting, even though they really can take care of that patient that requires pill medications and a dressing change, that patient is unstable. More than likely, that new nurse or that novice nurse would not be assigned that patient. And so leadership, that, so it's so important to know, your role when you do decide to go to a place to work. As I mentioned, when you do sit down for that interview, you want to make sure that you're looking at those responsibilities. What happens? What's the worst day case scenario? What's the best day case scenario? Ask those people that you're sitting down and interviewing with that information. What is expected? Am I going to be all new nurses going to be working this shift? Or is it going to be someone that we can go to that's going to be routinely scheduled when new nurses are working? So that communication piece, being communicatively competent, it requires communication to be both effective and appropriate. So, like, what are we talking about? So, in the event that you go to a setting, you need to know, not beating around the bush and just outright, asking, well, are there going to be other new nurses working? And if so, what is our protocol? What's our steps in the event that an emergency, happens? And so both effective and appropriate, that's communication being competent. It requires that communication be both of those. Effectiveness is usually achieved when that we say that they're achieved when those goals of communication are met. If you talk to your team leader, your director of nursing, depends on what setting you're in, they do have these different titles. And you found out what to do. So that goal has been met. So that's when we say that the communication has been effective. So appropriateness is achieved when the communication is well adapted to the people and the situations. So if you're taking care of a patient in room 201 and they speak a different language, their primary language is German, yours is Spanish. we need to translate that information over in German so that that communication is considered appropriately and so that it is effective. Because otherwise, the client is not going to understand what we're trying to communicate to them. So we need to adapt it to the person and the situation that it actually involves. A lot of facilities have videos. They do have different types of handouts, depending on like the grade level of their, of their understanding. So appropriateness is achieved if communication is well adapted to the situation, and then the person that is actually involved in that care. The patient. Do this needs to be in a second language? Do we need in the first language? Do we need a translator? Um, for sure we're speaking in layman's terms anyways, because for the most part, our patients more than likely probably not going to be healthcare providers. So we do want to, make sure that when we're talking to the patient, remember that we're speaking to the patient rather than to coworkers. You can, use all these huge terms and everything, but just making sure that they can understand, because we do want them to make informed decisions about their care. So we want to make sure that our communication is appropriate, that is effective. And we talked about, um, this being a continuous thing. It's just an ongoing thing. We're life learners. And so let me just pause there and let you think about that. I already gave you what would the nurse do with the client being the new nurse, with the client needing pill medications and a dressing change. The only what the difference was the patient was unstable versus stable. And then you all did answer saying that that new nurse, that novice nurse, should take care of the client that was stable. Okay, so here's another example. So let's see. Let me talk about communication a little bit more. And then I'm going to ask you about a tool that we use. And you all something should be popping up in your head. A tool that we use as nurses to communicate consistently and accurately about our patients. That's a tool that we use. Actually, the Institutes of Medicine, they recommended this tool to support to support effective communication. So whether or not we're on that phone, whether or not we're changing shifts, whether or not we're on the phone calling a healthcare provider, and if the healthcare provider is in person, this tool that we use so that we can communicate effectively. What is that tool called?
SBAR.
The S bar. Okay. So on your paper, you don't have to put it in the chat, but just make sure that you know what those letters mean. SBAR. So I'm going to give you like a minute on your paper. What does S bar? What's the S mean? What does the B mean? And then what does the A and the R mean? Okay. So chain of command. This is a big one with leadership. Chain of command. It is a part of pretty much every organization structure and communication. And it should not, but it should not. Chain of command is important for organizational structure and communication, but it should not stop, hinder, or impede patients that are needing urgent care or urgent attention, because then we're looking at jeopardizing the safety of this client. So while the chain of command is important for organizational structure, and then you all can recall many times when you've had to write emails, we said include the course lead, include your campus dean, include online dean Graham. So that's an example of a chain of command. But while you will go into these different facilities, and you probably have seen it yourself, you went in, you had the clinical instructor, you had your team lead, and you had to charge, like I say, the director of nurses, the ADON, the assistant director. And so in these facilities, they do have these different titles, but it's that chain of command. And it's needed for organizational structure. And so that patient care, all different components are met, and so that care just continues. But the chain of command should not stop or hinder patient care in the event that there's an emergency. In emergency situations, more than likely, if it's emergent, we're going to need an immediate action. So bypassing that chain of command is what we'll have to do. Healthcare professionals, we have a duty to report critical issues directly to who can address them promptly. Oh, I'm gonna wait. It's almost shift change. Oh, my team lead, ADON or director, whomever, they're on break. They'll be back in 15 minutes. No. We have a duty to report critical issues directly to who those can address them promptly. So while we do know that chain of command is a thing and it is necessary for organizational structure and communication and for things to flow, but the thing that changes what I'm talking about, excuse me, is emergency situations. And that is when we usually bypass that chain of command, especially if that patient is so critical that an immediate action is necessary. Okay, we have a duty to report critical issues directly to those that can promptly address them. So even if it's shift change, but whatever's happening right there, that patient still belongs to you as that nurse. So, but following that chain of command, and so we do, but we just have that little piece, like the gray area or the fine print. The fine print is if this is an emergency, then we need to go ahead and report that, even if it's almost change of shift or whenever in lab calls or X-ray radiology call. Usually, if they're calling, they're reporting something that's urgent, and it's lab results, X-ray findings. Because usually, if it's not urgent, you'll just get the report, or it'll just show up in that patient's electronic health record when you click that section. If they're making a phone call, there is something abnormal, and that warrants reporting that promptly, which then we might have to bypass that chain of command. So being in healthcare, it requires us to be flexible. We do want to use good judgment, and that's when it goes back to being competent as a nurse. And so knowing that we are life learners, looking at the latest evidence, not using or reviewing outdated information. When we have a chance to learn, go to different conferences and things, then we want to go and get the latest information. So facilities will have their policies and procedures also, though, that directs us what to do in urgent situations. And it's going to include whoever gets that information is going to report directly to whomever that can address it. And so that chain of command, any questions about the chain of command and when we bypass it? Any questions about that? Okay, so let me do what would the nurse do? What should the nurse do if they saw two coworkers, well, they overheard two coworkers talking about one of them's back pain, and they actually saw one of their coworkers take some of the medication and not put it inside of the medication cup, but they put it in the medication cup, but they actually took it. You actually saw them put the cup up to their mouth, drink some water, and swallow the medication. What should the nurse do that observed this?
Report it to their supervisor.
I heard a report to the supervisor. We agree with that. Okay. Not hearing either way. What if we just overheard them, the two nurses talking about the back pain, and they were one of them said, okay, well, I know patient in room 201 gets this type of pain medication. I heard that it really, really works. And so I'll just get it and put it in my pocket. This is just the conversation that we're hearing. So that suspicion is there. What should that nurse do?
Confront them about it, right?
We have confront them about it. Did we agree,
Shouldn't we,
disagree?
shouldn't we report that to like the superior?
You're supposed to report it to your charge nurse.
Okay. All right. In both instances, we're going to report that to the charge nurse. One of them, there was suspicion, and the other one, we actually saw it. Now, the next steps is more than likely going to be a statement. They're going to probably want you to write out a statement, whether or not it's electronic or in writing. But we want to go ahead and report that. Both instances, one was a suspicion because remember we overheard the nurses talking, and then the other we actually saw it. And so we do want to, of course, follow that chain of command and make sure that we're reporting it, even if it is a suspicion. Okay. So, okay, I'm gonna give you another what if, but let me talk some more about let's move into delegation. So that's a big thing. So when we delegate a task to the unlicensed personnel, are we relieved of whatever that task has been delegated?
No, you're still responsible for it, but they're just doing them.
Okay. So let me back up. So when we're delegating, when the nurse is delegating a task to the unlicensed personnel, are there things that we should consider about the unlicensed personnel or the patient?
Yes, I think we should consider that they can and they are able to perform the task that we're expecting them to do.
Okay. Anyone else? Anyone else? So the nurse is responsible for supervising patient care to ensure that it is competently delivered. So even though we delegated, the nurse is still responsible for supervising, ensuring that the care has been competently delivered. So when delegating tasks, before even delegating, we need to consider, well, hey, is this on the skills list of things that they can actually complete? Are they competent to complete this skills list? And usually, they usually have like this, this list somewhere that say, that shows what everybody's checked off on and things like that. And so that will show that their task list of things that they can complete. So before delegating those tasks, we want to make sure that that person is competent to even take care of that, to complete the task. And then the other thing about the patient, we want to make sure that patient is stable versus unstable. Because if it's a task that that unlicensed personnel can complete and that patient is unstable, then that's a task we wouldn't delegate to that unlicensed personnel. So the nurse is responsible. Let's go back to that first question I asked. The nurse is responsible for supervising that patient care to ensure that it's competently delivered, even though we delegate it. We want to make sure that patient is stable versus unstable, because in the event that it is a task that person we're delegating it to can complete the task because they're competent and it's one of the tasks that they can complete, but that client is unstable, then we would not even delegate it. So delegation of patients' care to other healthcare providers is one of those tasks, responsibilities of being that team leader. So we just want to make sure that we consider all of those things. Is this patient stable, unstable? The person that we're delegating this task to, is it in their skill set that they can actually complete this competently? So then we move forward with that. Okay, so let me just do another. What should the nurse do? What if we talked about reporting promptly? So the nurse called, changed the shift or whenever it was, the nurse received a call from lab and they have a critical lab bag. They received a call from radiology. They have a critical x-ray report, some type of report, echocardiogram report, whatever it is. The nurse calls the physician, the healthcare provider. They follow the procedure that the facility has in place to notify that healthcare provider, which is to page them, to call them, leave a message, and the healthcare provider does not return the call. Even if you call those numbers, the answering service usually will do a statement where it says, hey, if you haven't received a phone call, you should expect a phone call from this person within 10 minutes. Even if I've even called pharmacy and they say, hey, and they have these answering services on, which these people don't work in the pharmacy, but they'll say, hey, if you haven't received a call, well, you should expect a call within 5 minutes or 10 minutes from, the on-call person. Okay, so here's the situation. Let me go back again. So what should the nurse do? The nurse has received a report, whether or not it's lab, x-ray, radiology, whatever, and it is of urgency. So more than likely they're calling. If any of those, the lab calling or radiologist calling, more than likely there is something abnormal, an abnormal finding. So the nurse gets the information and they alert the healthcare provider via a phone number, via, they have these things in these electronic health records where the doctor will get this alert. However, that facility, whatever their facility's policy is, but the healthcare provider does not return the call. What should that nurse do?
Try to call again.
Okay, call again. Still no answer. What you do? What should the nurse do?
You report it to the higher up.
Chain of command. Knows who's next in line. You, and then who's. Okay. So yes, so that's what we would do. Because sometimes there is, something happens with whatever devices, or the healthcare provider might just not be returning the call. We don't know. We just know the nurse has information that has to be reported to someone that should be able to address it promptly, which more than likely is their healthcare provider. Even if there's sometimes where patients, for example, if they come to the hospital, their doctor doesn't have privileges there, so they'll be seen by a hospitalist. And so there's someone's usually always available. But sometimes, people go on breaks and things like that, and you can't get them. What do you do? What if this patient, you have a home health client, and you've called, because some home health agencies have their own staff, like their own physician, but then they also have a method where you call that individual patient's doctor. You can't get anybody. What if you're at the long-term care facility and I don't know, it's a holiday, staff is few, the normal staff is not there, or it's not the routine day that the healthcare providers are making rounds. And or maybe it's just second or third shift. And something we get that call from the radiologist. They drew labs earlier that day. And so they're calling us with lab results. We know that we do the beeper, the pager, we call the answering service, we send the electronic message, no answer. So yes, remember the client's safety is priority. And so in the event that we're not getting that direct call, because we're fulfilling our duty to attempt to report to someone that can address it promptly, but we're not getting that return response. So then we must activate that chain of command to assist us in seeing what are the options we have. Sometimes they may have a different number, they may have an alternate schedule, and also that healthcare provider may have a shadow covering, which means sometimes if you can't get them, that team leader, that director of nursing, that charge nurse, they may know if we can't get the main doctor, then the next steps would be to notify the next person. All of that to say, knowing that when we should use the chain of command, sometimes we have to bypass the chain of command, and that's in emergency situations because if that client's safety is at risk, and we have an issue that needs to be promptly addressed. In the event that there's suspicion, or if we outright see, and that's called abuse, when a nurse is taking the client's medications and using their belongings and things, we must still follow the chain of command and report it. We must report that. So going back to our initial conversation, must be competent. And in order to do that, we have to continuously learn, gather more information, evaluate ourselves. I don't really understand this. So I need to make sure I need to review this, read some more articles on this. Let me see what's the latest evidence out there about whatever this concept is so that we can improve upon our skill set. Not only has the Institute of Medicine recommended training for us to use to practice, support our effective communication, which is the SBAR. the essence situation, like why are we calling? The background, we give all the, the history. What are our assessment findings? And then the recommendation. That's that tool. No matter if we're handing off shift or if we are actually having to make that phone call because we have some urgent or abnormal findings, we still use that tool to help us to communicate effectively. And we said communicating effectively it is achieved when the goals of communication are met. Our goal was to contact the healthcare provider to let them know about these findings and to get a response. The goal was met. We talked to the healthcare provider. They gave us new orders or they said no new orders. So, and then we said that competence in communication requires both effective communication and appropriate. If it's not in my language, if it's not where I can understand it, then it's not appropriate. So we want to make sure that people can understand it. Okay, any questions about so far about leadership? For the most part, we talked about chain of command and we kind of peeked at delegating. Any questions about that? So while you would think that communication and all those wouldn't be heavy topics, they really are. So once we actually, we're going to pull up our PowerPoints here in a moment. I just want to give like this overview because I know we don't have a bunch of time here, just so that you can start thinking of where we're going. So communication can be assertive, it can be aggressive, and it can be passive. So we want to tell the truth. We want to establish early on these therapeutic relationships with our patients. So in the event so that they won't be afraid to tell us, if they don't want to treat, if they don't understand something, so they'll be forthcoming with that. And so, but trying to establish that therapeutic relationship does not mean we as the nurse try to change policies and procedures because we want to be nice to the patient. No, I'm not saying not be nice to the patient. We want to be assertive, making sure that we're honest with our communication and that what we're communicating is clear and honest to that patient. We don't want to be aggressive and we don't want to be passive either, because passive is we just passing the buck. While we don't want to hurt our patients' feelings, what we're thinking, and I'm sure they rather know the truth about, hey, well, we can't do it like this because the policy is to protect you and me, the nurse and the patient. And so a lot of times it's just explaining to the person where they can understand it, then they're okay with what we're trying to get them to do. But assertive, we want to be assertive. That's being communicating effectively. We're being honest, and then we're highly valued as we already are as nurses on that healthcare team. So passive, aggressive, and assertive. Those are some topics that we'll talk about, and we'll give you some scenarios. But like I said, we don't want to change rules because we want our patients to like us. They rather we tell them the truth, be honest, and be forthcoming with it, but not aggressive. So because we're advocating for those clients to make their own decisions. And as part of them making their own choices, the clients need to be able to understand and have information so they can make that informed decision. I know I keep saying that, but that's really what it's all about. It's their care. They have a right to choose to proceed or to say no. So we should continuously advocate for the client in a professional manner. We shouldn't be aggressive with our coworkers or be aggressive with the others on the healthcare team. We shouldn't be passive either. We should speak up and be honest. I think last week, or it might have, I'm not sure when it was, we were talking about the client that came to the nurse and said, hey, I just signed that consent because the doctor was in here. And then you as a nurse walk in, they say, hey, I really didn't know. I just signed it. I really don't know what they were talking about. Can you explain it to me? And so we get that doctor back in, or whomever that is, whoever got them to sign that consent, and to go back over it so that the client is making an informed decision. So we're all the time advocating. It's a continuous process because we do want the patients to make their own decisions. And so, and whatever they decide, we call the doctor back in and say, hey, they signed this consent, they changed their mind, or they signed this consent, they need more information. We want to inform that healthcare provider about whatever those clients' wishes are regarding the treatment that they are getting ready to receive. Or even if, like I say, if they even this treatment they've started and they decide, this is just not for me, then we still inform that healthcare provider. We want to act in that client's best interest. Okay, let me pull up our PowerPoint here. So I kind of just gave us a huge overview of where we're going with this communication and leadership focus here. Share our screen here. And you'll be given this PowerPoint as well. It should pop up here in your announcement section. I think on tomorrow. Let me share here. All right. It says, which statement best describes the primary difference between leadership and management in healthcare organizations? Okay. So leadership is future oriented, visionary, while management just focuses on the present operation. So I'm not sure if you really thought about that, but you're that leader. It's like, okay, yeah, you're focused on more than just what's going on right now. But what do we see? That the staffing patient ratio should be in a couple of months. And what are those things that would take it, that are needed for, patient staff ratio to be, what it should be in a couple of months. Another example is what, as that leader, what are we looking at? What do we envision for falls? Like, for example, falls is a big thing in acute care settings and, in the long-term care settings. There's a high risk of falls. So as that leader, we're thinking about how can we decrease the numbers of falls in our facility. And then, what are the pieces that will equal that? What do we need? And so that's my little mouse doing something. So leadership again is future oriented and visionary. What do you see for the future? While management just focuses on the day-to-day operations. Now it does take the day-to-day operations to get to the future, but right now we're thinking about more than just today. Okay, so which of the following best characterizes trait theory in leadership? So trait theory suggests leaders possess inherent qualities such as drive and self-confidence. Not being aggressive and self-confidence is, hey, it includes, I need some help. I don't understand. I don't even know what this is. Let me stop for a moment and research it. Ask my team leader. So being self-confident does not mean that you have all the answers, but it also includes that you are confident enough to know that, hey, I need some help and I need to call up on someone else or, do some more research. Okay, I think this one right here. Let's do this one. In the chat, let me move this little bar out the way. Just put A, B, C, or D. Which scenario best exemplifies transformational leadership in nursing? So I'll give you a minute. Let me put my little timer on. And in the chat, you can just put A, B, C, or D. Let's find this bit. Okay, start. All right. So a nurse manager who motivates staff to embrace change and empowers them to act. Now, knowing that this embracing this change and that empowering to act, meaning, research, that could include, doing smaller focus groups, doing one-on-one teaching, do one, teach one back, and things like that. So there are many steps to pieces to this empowering others to act and embracing that change, which is a good thing. It's not a bad thing. Our little minute was up. Let's see. I don't think we need to go over that one. Okay, so shared governance in nursing leadership. So shared governance involves collaborative. Think about the word shared. So we're collaboratively deciding things. So shared governance involves collaborative decision making and accountability among nurses. What are we as this unit going to do to help with our patient nurse ratio? How are we going to address call-ins? Like, what are we going to do? Like, what are our steps? We sit down and talk about it, and then we're accountable. We want to hold ourselves accountable for following through, even though I know we all don't agree. We all have different ideas, but we should be able to come to some common ground and then be accountable. If we're saying, hey, the next week, let's try to, I don't know, do more rounds or only call in if you're sick or whatever the goal is. And then if you're on that team and you've shared in making that decision, be accountable. Don't be that person, the first person to call in or not make the round or whatever it is that the decision, whatever that decision was. Okay, so middle level nursing managers supervise multiple first level managers and focus on planning and coordination. Like I said, it depends on what facility you're in. They have these different levels, that chain of command. But just know that there always someone there that can assist with decision making and or assistance if you get in a situation and you're that novice nurse and unsure what to do. So transformational leaders challenge the process. So another word that we used to use, a phrase we used to use was like spirit of inquiry. So that person challenges the current process. Not that the current process is wrong, but we're just trying to think outside of the box, think above the box, or on the left side of the box, or the right side of the box, to see if there are any other steps that we can do. We're not going to practice against our state practice nurses act. We're not doing anything that's not unlawful. Now we stand within the state nurse practice act. So we're doing things that are on our to-do list that we can lawfully do. But can we do this procedure or can this process be done differently? Can we take out step 3 and move it down to, can we flip this step 4 and 5? Can we save time? Can we use less resources? Can we use less manpower? So transformational leaders challenge the process, not because we don't want to do it, but we generally are trying to see, can this patient have better outcomes, best outcomes, as well as the staff. And it inspires shared vision, and then we recognize those contributions. And so that's what you sometimes will see when you go into facilities. People have the Daisy Award, or they may have these different awards within the facilities. I think the Daisy Award is a national thing, but facilities themselves will develop some system of recognizing contributions of the team members. But traditional transformational leaders is not that we're trying not to do what we're supposed to do to take care of the clients, but we're just trying to see if there's a better way using less resources, manpower, and things like that. I don't think we need to go down one. And like I said, you'll get all these slides. Some of them I'm going to skip through. Servant leadership prioritizes the needs of others and community building. And the community building is it could be specific to units. This is, within that unit, we're not necessarily talking about, we can't be talking about in the community, out in the community itself, but you have the, med surge, one west, east, and have these different, but that in itself is a community. The different floors, these floors take care of, bones, strokes, and so forth. Within those are communities. And so we are just thinking about, what's priority? What can we do to provide that best care for our clients? What can we do to facilitate our staff, our nursing staff, the others on the healthcare team to provide that best care, to prioritize, think it through, and provide that best care for the client. And an example that comes to mind, I think I mentioned it before, where the patient is supposed to be receiving physical therapy, but also has an appointment, a referral appointment outside of the facility. We don't want both of those things to be occurring at the same time, but because we want the client to get both of those. So we need to prioritize, well, hey, can this client, today is Tuesday. Usually, therapy comes on Tuesdays at 10. So we need to make this appointment, at this time, flip them or whatever, but just prioritizing that the client's needs. Okay, I'm going to stop sharing here and ask, are there any questions about the information that we went over? We did not take our 15-minute break, which we usually leave it toward the end anyways. And so there aren't any questions. This is our time that we will end and go on our break. And we'll see you on next week. Remember, the exam analysis takes place on Friday at 5 p.m. Eastern Standard Time. So within about an hour, grades should be pushed out. Are there any questions or concerns? Make sure you place your name and campus in the chat. If not, we'll see you next week.
All righty. Bye-bye.
Have a good week. The nurse has a duty to act in the client's best interest. If the care the client is receiving is unacceptable, we as a nurse, we must advocate. Okay, we must advocate. And so just think about some situations. Are we having to question orders that we have written? Like, for example, we see that this is a much higher dose than usually prescribed. We see that this client, we are administering blood pressure medications and the client is compliant and this blood pressure is still out of range, it's still abnormal. We just talked about the client where we're contacting the doctor and the doctor's not calling us back, they're not responding. Where we seek further assistance, the client is even if the client's getting ready to be discharged, and the client, even if they're leaving AMA, against medical advice, and we do realize the client hasn't had all of their medical evaluation, we want to make sure that this client is aware that they have not been evaluated completely. And even if is checked off that the client has been evaluated, this is a different situation. The client's been marked off on, and we see that, well, this right here, there's an order for a CBC. They haven't even drawn blood for this client. So we must seek clarification. We must advocate. We must question inconsistencies. We must seek further help if needed. We must seek clarification. The nurse has a duty to act in the client's best interest. Okay. So the ability to voice one's ideas and thoughts assertively, credibly, and confidently is highlighted as a highly valued communication skill and is critical to effective advocacy in nursing. So we want to be assertive. We want to be honest with our clients. We don't want to be passive and not give them information that we have. And we don't want to be aggressive with them. We want to be assertive. We want to, is a communication skill that is critical for effective advocacy in nursing. Okay. Hospital readmissions. That's a thing that hospitals look at. Even insurance companies, they look at. Hospital readmission rates are often attributed to lack of coordination of care as patients are being discharged. Did we give report? Did the long-term care facility really know that this client needed oxygen? Did the home health nurses, did they really know this client needed oxygen? If they did they set it up? Did they realize that this client was going to be discharged on this day and the health supply store was going to be closed? So how are we going to get this oxygen that's needed? That's just an example. But hospital readmissions, they are attributed to that lack of coordination and communication of care for the patient. So it's very important for those that are on the team, everybody on the team, all the members, to coordinate that patient's care. Well, as we kind of briefly talked about delegating. So keep in mind of those tasks that we would not delegate to an unlicensed personnel. You administer medications, inserting Foley catheters, doing dressing changes, going in doing assessments. These are things that an unlicensed personnel would not do. Now, things that unlicensed personnel can assist with, they can assist with like personal care, assisting with bathing. They can even obtain that glucose measurement, but they cannot be interpreting or doing any teaching about the number of the results that they actually got. Team nursing involves small teams led by a registered nurse assigned to care for groups of patients based on the patient's needs and the team member's skill. Okay, that's that team nursing. Functional nursing is task oriented, team nursing. Functional nursing is task oriented. Team nursing is you're focusing on the team members and the skill set that they actually have. Case management focuses on delivering cost-effective quality care to clients with complex needs. That's that case management. That person usually has several. It's a complex case, so that they're so we say anyone can have a case manager, but usually we say that for those clients that have those complex needs, they have probably several conditions, that several chronic conditions that they're trying to manage. So we talked about team nursing. We talked about case management. And then we said functional nursing was task oriented. Client satisfaction and positive outcomes occurs when care is client centered. Truly, clients, their satisfaction comes from knowing that, we as that nurse and those people on the healthcare team, that we did our best. They were informed. They felt like we were being honest with them. The Institute of Medicine originally defined patient-centered care as providing care that is respectful of and responsive to the individual client preferences, what they needed, what they value. And so client satisfaction and positive outcomes occurs when care is when the clients are satisfied and they have those positive outcomes. Okay, so let's talk about autocratic, democratic, laissez-faire. We've already kind of talked about transformational and then transactional. Transaction, we're transacting. There's a rewards. There are rewards for performance. There's a transaction that occurs as a result of. So, and then we say laissez-faire lets the team work independently with little guidance. Oh, you just take a break whenever you want to. Oh, we can just feed the patients whenever. So lazy fair, that approach is we just let everybody pretty much do what they want to or independently with little guidance. Okay. So autocratic, the nurse sets the rules, give the orders, and expects tasks to be done without staff input. Auto. That one person self is making all of those rules and everything. So with democratic, manager asks staff for input and includes their ideas when they're planning. Democratic considers others. It's the opposite of autocratic. Autocratic, this is how we're gonna do it. This is what we're expecting to be done. Democratic does consider input and includes ideas of those others when planning. Okay. And then we said transformational inspires staff with shared vision and encourages growth. We talked about that. Transactional. There is a transaction that actually occurs. That it may include rewards. We give out rewards when goals are met and consequences for are met for the different goals that were set. Empowerment, empowering staff to participate in improving patient care and creating work environments that foster professional practice is a key principle of effective nursing leadership. Remember, a transformational leader empowers others and sets a vision for that organization. Remember, we talked about what's to come, what's in the future. It's more focused than just that day to day. It's more than just the day to day.